Well, thank you for joining us and welcome to MLI's Community Collective, Harnessing the Power of the Community to Battle Obesity, an activity supported by an educational grant from Lilly. This is the second of a three-part series, Practical Application of New and Emerging Data. If you missed part one, just use the same link that you used to join us tonight. You will be able to watch the recording for activity one from that screen. Next week, we will all meet together for a live in-person event at M. Bird atop the historic Armature Works in downtown Tampa on Thursday, September 26th. Our hope is that after listening to both parts 1 and 2 of this series, you'll come prepared with any remaining questions or challenging cases. Don't worry, you don't have to write them down or submit them. But really, this exclusive event is for you to network with your colleagues so that you feel comfortable making a difference in the lives of your patients who face the challenges and comorbidities that come with overweight and obesity. And don't worry, if your colleagues weren't able to join you tonight, this information will be available to them at their convenience. We will put that link in the chat so they can view it prior to our get-together next week. So, tell your friends and make it a date. Before we start, let's warm up with a few pre-test questions. Mr. J is a 50-year-old Caucasian patient with a BMI of 34 kilograms per meter squared, which is categorized as a class 1 obesity. If his waist circumference is 122 centimeters, what is his disease risk relative to normal weight and waist circumference? Pretest question 2. To facilitate shared decision-making, what counseling and education points would you provide a patient regarding second-generation anti-obesity medications, allowing them to make an informed decision about their therapy? Pretest question 3. A second-generation anti-obesity medication was initiated in your patient 2 weeks ago. They report that they have been experiencing some gastrointestinal issues. Which of the following is the best way to manage these common side effects? Thank you for participating in that. So we will be monitoring the chat. Feel free to ask your questions there. And thank you to everyone who is joining us on YouTube as well. With all that said, it is my great pleasure to introduce one of the leading experts in the field of obesity medicine, Dr. Lisa Ferreira. For those of you who were unable to join us last week, Dr. Ferreira is an obesity medicine specialist practicing at the Advent Health Bariatric and Metabolic Institute in Tampa, Florida. Board certified in family medicine, medicine, and lifestyle medicine, she is a fellow of the Obesity Medicine Association and serves on the board of directors for the Florida chapter of the American Society for Bariatric and Metabolic Surgery. Dr. Ferreira is also a founding member and current president of the Florida Obesity Society. Dr. Ferreira, thank you so much for joining us, and I'd like to turn this activity over to you.
Excellent. Well, thank you so much for that introduction. And thank you all for being here again. I'm going to share my screen so that I can advance our slides. So hopefully we're all seeing my screen there. I think so. All right. Well, thank you again so much for being here tonight. So it is my pleasure to be able to come to you and talk to you about the disease of obesity, something that I'm really passionate about. Again, my background is in family medicine. And so in family medicine, of course, we are seeing more and more of our patients struggling with weight and those health consequences that are related to weight. So it's great that you're here so that we can talk about how can we actually apply some of our knowledge and our tools to help our patients with this chronic disease. So again, just to summarize from last week, treating obesity as a chronic disease, we know that obesity is a disease that is relapsing and that is prominent and is difficult to treat. We know that patients try to lose weight numerous times, and it always seems that the vast majority of the time, the weight comes back. And so we know that it is a complex multifactorial condition. The definition of obesity also includes the excess body fat that is there with a patient and the consequences of that. So, and we'll get into more of that here in a minute, but it must be viewed as a chronic disorder, as it says here, and it needs close follow-up. So I know I'm preaching to the choir. I know all of you buy into this idea of obesity as a chronic disease, thankfully. And so now we're going to talk about ways that we can help our patients. I also remind our patients when they come in that this is not something that they can necessarily will away, or they just need more willpower, or it is that they need to work harder. This starts with genetics. And so you can see on the right side of the screen here that genetics can play up to about a 70% role in predisposing someone to develop obesity. And then you put our environment on top of that, and factors like our behavioral health, sleep deprivation, stress, our food environment. There are so many factors working in against our patients. So we're going to talk tonight about a case study. We're going to talk about Mr. J. And Mr. J, we met him a little bit in the first questions. Mr. J presents in your clinic for his yearly checkup, and he's also telling you he's a little more tired than usual. So this is Mr. J's medical history. It includes obesity, type 2 diabetes, hypertension, dyslipidemia, sleep apnea, MASLD, gout, osteoarthritis. A lot of these conditions that are obesity related or are linked oftentimes to obesity. And you can see his current medications listed here. So he's on metformin and amlodipine, empagliflozin, glimepiride, rosuvastatin, allopurinol, and losartan hydrochlorothiazide. So Mr. J comes in to your clinic for his routine checkup. He had his lab work done, and you see his physical exam findings as well on the right side of the screen. So what you can note from this, obviously, when we look at his diabetes, does not look like he's having much control. A1C at 8.1, glucose 190. You can see his blood pressure is high. He has dyslipidemia. Triglycerides are quite high at 360. We can also see his vital signs that his height and weight are listed there. Waist circumference at 48 inches, BMI 34. Liver enzymes are elevated. His FIB4 screen is high, which is a screen we use based on lab results to determine someone's chance or risk of having fibrosis. And his coronary artery calcium score is also high as well. So going back to that first question that you saw, so looking again at Mr. J's risk. So if we go back again and we see where he is with his waist circumference and BMI, waist circumference at 48, BMI at 34. So let's see, we'll try our test question, and we'll see what would Mr. J's risk be at this point? So I think I buzzed through it a little fast for you to be able to refer to the chart. But if you want to try to answer the question again so that we can see if you have a different idea about what his risk would be. I think everyone pretty much got it right in the beginning when I was looking at the numbers anyway. And I think I didn't help you out. I didn't leave the chart up long enough. Right, so I am going to end our poll then and take a look at that with you. All right. So actually what we see is that the answer would be very high risk. So let's take a look and see why that would be. So when we look back at Mr. J, we know that his weight was 258, his height was 69 inches, waist circumference at 48, BMI 34. So when you look at our chart, by BMI, he would be class 1 obesity. But with his waist circumference being over 40 inches, that actually puts him at very high risk of disease. So again, thinking about the difference between just BMI and our waist circumference, and knowing that waist circumference is really more indicative of what we think their risk is going to be. It's that visceral adiposity that really presents a problem metabolically. So Mr. J's risk is going to be very high. So thinking about treating our comorbidities and our complications of obesity, you can see on the left side of the screen, and I think we went over this one last time, to look at the amount of weight loss that it takes to improve these comorbidities. And so the ones listed on the left in the box are what Mr. J is struggling with. And you can see on the right side what it takes to really make some improvement, or even in the middle. So say hypertension, for example, even just a 5% body weight loss can really make a difference in Mr. J's hypertension. So knowing that it is worth treating obesity because we are going to most likely make a difference in these comorbidities at the same time. So when we think about how to help someone, we know that we start with our lifestyle intervention, of course. We know we're going to talk about nutrition. We're going to talk about our physical activity. We're going to try to tailor some treatments that way. And then when we start thinking about medication options to help our patients, we're going to go through, how do we make that decision? How do we decide what to do? So the first thing we think about are the drug factors. So we think about the efficacy and the safety data for our medications. And we also think about the benefits that can come from these medications. Oftentimes when we use a medication, we think about, can we kill two birds with one stone? Can we treat two things at one time or more? So thinking about Mr. J and thinking about his type 2 diabetes, this is the newest treatment algorithm for type 2 diabetes. And you can see on the left side of the screen, we're also looking at patients who have cardiovascular risk. And so how would we pick a pharmacotherapy for those patients? So ASCVD or heart failure, CKD. And then on the right side of the screen, it shows you the approach you could take when we're also thinking about obesity and treating weight. So we're going to blow that side up and we're going to take a closer look at that. So when we think about treating diabetes in our patients, of course, again, we're going to start in our lifestyle intervention. We're going to start talking about those eating patterns, and we're going to talk about physical activity. But we're also going to consider medications based on, number one, what's going to help their glycemic control. But number two, what may also be much more weight friendly or even promote weight loss for our patients. So you can see on the right side, the medications that are commonly used are listed, and they are listed from very high as to how effective they are for weight loss down to neutral. So for Mr. J, we do want to get some better glycemic control, but we also want to get some weight loss for him. And so we see here that the medications, as we already know that semaglutide and tirzepatide can not only be very effective for weight loss, but can also be very effective for our glycemic control. So that's usually where I would start or think about starting in our patients who need help with their type 2 diabetes, but also their weight. In addition, we do have more data these days about the cardiovascular benefits of these medications. So thinking about that aspect as well, and really trying to deliver the best care we can with the best medication we can to treat the most disease states that we can. Now, metformin is listed here as a neutral, and just to throw out to you that I do tend to use metformin in patients because I tend to find it does have a little bit of weight loss associated with it. The other thing we do have to think about with these medications is cost and coverage with our patients. So we have to do the best we can do within those constraints as well. And so we'll talk about that a little bit more later also. So looking at those medication choices, looking at specifically semaglutide and tirzepatide, we have them studied in different areas. So when we do trials or when trials are done on these medications, semaglutide and tirzepatide have gone through trials for type 2 diabetes approval, and they have also gone through trials for obesity approval. The trial names for when these were approved or studied for obesity treatment for semaglutide are the STEP trials. And you can see the step one, there are steps 1, 2, 3, 4, 5. There are extended steps looking for other benefits in other disease states as well. But basically, these are the weight loss trials for semaglutide. And you can see in the middle of the screen the primary endpoints, the change in percent body weight loss over placebo. The SURMOUNT trials are the names when they're used to assess the weight benefit for tirzepatide. So the tirzepatide trials are named SURMOUNT. And fortunately, they seem to follow each other in their numbers. So step 1 is set up pretty similarly, looking for the same result as SURMOUNT 1. These initial trials, step 1 and SURMOUNT 1, were done to get the initial approval for semaglutide and tirzepatide to be used for obesity treatment. So again, you can see in the middle of the screen here the efficacy and the change in body weight loss the change in body weight that's happening in these trials, and the weights on the side, or actually the right side, is what percentage of patients in these studies were able to get a 5% or more body weight loss. So you can really see that these are very effective for weight loss in our patients. But we also know that these are very effective in treating diabetes, and we'll talk about those more as well. I also just wanted to mention to you that new indication for semaglutide, 2.4 milligram dose. So the weight loss dose is the 2.4 milligram. And on March 8th of 2024, thankfully, the FDA approved using this dose of this medication for secondary prevention of cardiovascular disease. So what we found is that patients in this SELECT trial was the trial that was done to show that patients who had established cardiovascular disease and overweight or obesity, when they were on semaglutide 2.4 milligrams, were able to reduce their risk of recurrent disease. So it's basically now indicated for secondary prevention of those major adverse cardiovascular events. So cardiovascular death, non-fatal MI, and non-fatal stroke. So that's exciting news as well, because now we have a medication that's used to treat obesity, but also has another FDA indication, which hopefully will allow more of our patients to have access to this. Medications for treating obesity have been very difficult to get covered oftentimes because, unfortunately, there is still stigma. There are a lot of barriers to getting obesity medications covered under insurances. But we find that oftentimes when we see other indications come out for these medications, that insurances are more likely to provide coverage. And so Medicare decided to allow coverage for our Medicare population with cardiovascular disease for the semaglutide 2.4 milligram. So that is really very exciting information. So looking at our trial, so you can see on the right side the step 1 trial for semaglutide, for the initial approval of semaglutide for weight loss. And you can see SURMOUNT 1 on the right side for the initial approval for tirzepatide for weight loss. And looking at those graphs you can see, or the charts, you can see that the percent body weight change for the left side for semaglutide versus placebo was really pretty significant. You can see over a 16% body weight change there. And on the right side with tirzepatide, you can see the different doses of tirzepatide, 5, 10, and 15 milligram doses. And again, over placebo, the benefit you're seeing with the mean percent body weight change over placebo. So these really are the most effective tools in the way of pharmacotherapy that we have on the market right now to help our patients with weight. Now, looking at other trials, so SURMOUNT-2 was actually the trial for tirzepatide, or for Zepbound, that was with patients who had overweight and obesity, but also had type 2 diabetes. And so the endpoints were also looking at the mean percent body weight change. And you can see on the left side of the screen, the graph showing that the mean percent body weight change was still 14.7% compared to 3% of the placebo group at the highest dose of tirzepatide. So still very effective for our patients to who have type 2 diabetes to be able to lose weight as well. Oftentimes people ask, well, why was the weight loss here? Because if you remember on the previous screen, when we look back to the right side with tirzepatide at 15 milligrams, it looks like here the mean percent body weight change was about over 20%. But on the SURMOUNT-2 trial, because patients had type 2 diabetes, we know in these trials they didn't respond quite as well as our patients without type 2 diabetes, which just points to the fact that our patients with type 2 diabetes are struggling metabolically. And so they tend to struggle even more with weight loss. They tend to not respond as well to some of the treatments we use for our patients who are not struggling metabolically. But still, their weight loss was definitely significant. You can also see on the right side of the screen, this is looking at the difference in A1C in these patients as well. So these patients, remember, had type 2 diabetes and overweight or obesity. And you can see the changes in the A1C. So the starting A1C around 8. And by the end of the trial, tirzepatide 15 milligram resulting in an A1C down about 5.7. Which I think if our patients started with an A1C at 8 and we got them to 5.7 and they managed to lose weight as well, that would be a serious win. Now, SURMOUNT-3 was another trial that came out looking at tirzepatide or for weight loss. And these were patients without type 2 diabetes. The patients in SURMOUNT-3 were actually allowed to have intensive lifestyle change. So they were given more education on weight loss and nutrition and physical activity and monitored closely. And again, you can see the efficacy of the medication, that the mean percent body weight change was still 18 to 21%. You can see on the right side, 21%. So we're really seeing benefits in our patients. So now when we think about other trials with semaglutide and tirzepatide, when we look at our patients with type 2 diabetes, these trials, instead of the weight loss trials, for semaglutide, these were the SUSTAIN trials. And you can see here, the purpose of the SUSTAIN trials were to look from SUSTAIN 1 through SUSTAIN 7. They were set up a little differently and basically comparing either with SUSTAIN 1, different doses of semaglutide and how effective these are to treat type 2 diabetes, and also to see how effective they are in treating weight. These were not set up as weight loss trials. These were actually diabetes trials, but they also re-examined the data just to see how effective they were for weight loss. And so looking at the left side of the screen, the SUSTAIN 1, so semaglutide 0.5 milligrams versus semaglutide 1.0 milligram. Now, interestingly about these trials, when semaglutide was originally approved for type 2 diabetes, they were not studying the higher doses. So the semaglutide 2.0 milligram dose for our patients with type 2 diabetes didn't get approved until around, I think, 2022. So these trials, that's why you'll see the lower doses of semaglutide. But you can still see the mean percent body weight change, even when it was not specifically an obesity trial or obesity outcome trial. SUSTAIN 2 through SUSTAIN 7, you can see here at the bottom the medications that were compared. So the SUSTAIN 2 was comparing sitagliptin. Some of these were comparing insulin. So you can see overall the weight changes. And actually the SUSTAIN 4 trial showing insulin caused really a weight gain, which is often what we expect with our patients on insulin. Tirzepatide, these were similar trials. The names of these trials, when they were used for type 2 diabetes originally, were SURPASS or our SURPASS trials. And so again, fortunately, the numbers pretty much line up. But this time you can see at the bottom the medications that were compared. The SURPASS 1 was looking at these different doses of tirzepatide, the 5, 10, and 15 milligram doses that we have currently for obesity treatment as well. And so you can see these percent body weight changes. It does look like that with SURPASS 2, they did have a head-to-head trial with tirzepatide versus semaglutide, but semaglutide was at that 1.0 milligram dose because, again, that was all that was available at the time. So when you look at these numbers, we also have to think about the dosing that was used at the time, and they weren't using the weight loss dosing. There have been no head-to-head trials at this point, to my knowledge, of the weight loss doses of tirzepatide and the obesity doses of semaglutide. So we really cannot say, comparing Wegovy versus Zepbound, for example, which one has more efficacy, but they were comparing those in the diabetes trials. So we also want to think about our benefits to our patients beyond weight loss when it comes to tirzepatide and semaglutide. So yes, weight loss is wonderful, but the glycemic control is absolutely important as well. Now we know that weight loss can also help our patients with glycemic control as well. But you can see here in the tirzepatide trials, 5, 10, and 15 milligram doses, and the change in A1C. And so these patients starting out on this left graph at about 8.28 A1C, and then dropping down into the 5s and 6s with their A1C. You can also see on the right side the lipid changes when looking at tirzepatide versus semaglutide 1.0 milligram. And so what we know, though, is that all of these medications, or both of these medications, do really seem to be not only beneficial for weight, not only beneficial for diabetes treatment, but also may have some other cardiometabolic benefits as well. There are also other trials happening all the time. And I know if we open our news feeds and our social media every week, there's a news story about one of these medications being studied in dementia, in MASH, in PCOS, in sleep apnea. There are a variety of trials going on. So thinking about Mr. J again and his liver disease, and that he has MASLD, how do we get some benefit for him for treatment of that disease? And so back to our semaglutide and tirzepatide, could they also be helpful for liver disease? So you can see on the left side of the screen that participants had changes in their, or resolution in MASH based on the doses of semaglutide. Now, in this trial, interestingly, the doses of semaglutide were much lower than our therapeutic doses for obesity treatment, and yet you can still see the benefits on liver disease. And then SURPASS-3, here looking at when they analyzed it further and looked at other data, looking at the MRI results that were done in SURPASS-3 and looking at liver disease, you can see the change in the liver fat content by using these different doses of the medication. So again, we're seeing overall benefit with semaglutide and tirzepatide in multiple areas, which again is why I think they really do make great choices to start for our patients who are suffering from these metabolic complications of obesity. Cardiovascular outcome trials, we're seeing those these days as well. Now, these trials, again, remember SUSTAIN and SURPASS were our diabetes trials for semaglutide and tirzepatide. We're now getting more trials coming out with semaglutide and tirzepatide used in obesity, such as the SELECT trial that came out with semaglutide 2.4. But you can see overall, looking at both of the sides of the slide, that there are definite benefits to our patients. You can see the placebo, the patients with a number of events, of cardiovascular events on both of these sides were higher than when they were on either semaglutide or tirzepatide. So we are showing that we are getting cardiovascular benefits as well. Now, so I think I have shown you the benefits of these medications, and I probably did not have to convince you of that. I'm sure you've been noticing these in your offices as well. What we think about with these medications, though, a lot of times too, are, again, cost and coverage, and we'll talk about that, but also side effects. And so we really do want to be aware that as we're starting these medicines for our patients, no matter how well we think they're going to work, and no matter what we think we're trying to treat, if our patients don't tolerate them, we're not going to get anywhere, right? So we have to think about supporting our patients with these side effects. So the most common side effects on these medications are going to be those GI effects. So looking at abdominal pain, nausea, vomiting, diarrhea, constipation. And there are tips and tricks that we can use to try to help our patients get through these, and supporting them and educating them on these side effects, I think, really helps. If patients are aware and are prepared for these effects and have some tools and strategies to use to try to mitigate them, then they really can do very well. So we'll talk more about that. But these are the common side effects that you know. So we're going to take a question from a community clinician regarding these medications.
Are there any contraindications with novel anti-obesity medications? Are there certain patient populations who shouldn't be receiving these medications?
And so these are good thoughts, right? When we think about treating our patients, we want to make sure that we're also first do no harm, right? So we want to think about reasons we cannot use these medications. So when we think about these, our GLP-1s, receptor agonists, or GLP-1 GIP receptor agonists, we think about that black box warning. That is really the first thing to think about. So we know we have a contraindication if a patient has a personal or family history of medullary thyroid carcinoma, or a personal or family history of MEN2, that multiple endocrine neoplasia syndrome 2. The multiple endocrine neoplasia syndrome 2 is a syndrome that does include those thyroid C cell tumors. So really it is just the thyroid C cell tumors we're thinking about, which is medullary thyroid carcinoma. This does not include other thyroid conditions, fortunately. So it does not include patients who have had other thyroid cancers, such as papillary thyroid carcinoma, follicular thyroid carcinomas, thyroid nodules, hyperthyroidism. As long as it's not medullary thyroid carcinoma specifically, then it's not included in that black box. And we also, of course, know that we're not going to use these medications in patients who have had hypersensitivity reactions. These medications have also not been studied specifically in patients with a history of pancreatitis. Now, people think often that pancreatitis is in that black box warning and is an absolute contraindication. It is not an absolute contraindication. So I would just say, if your patients have a history of this, thinking about how likely are they to develop recurrent pancreatitis. For patients who have chronic alcoholism, or maybe chronic pancreatic insufficiency, or some reason that you're worried, then these may not be my first choice. But if they've had a remote history of gallstone pancreatitis, for example, then I might be comfortable, I would be comfortable using these medications. We just definitely are monitoring our patients, right? And especially with the contraindications. If we have a patient come in with any complaints in the neck area, we're going to work them up appropriately just to make sure. We also know that these medications have not been studied in patients who have been, for the weight loss trials, who were on insulin. And we know that we do not use these. They have not been approved for treatment of type 1 diabetes.
What's the worst call about a side effect that I can expect from a patient when I prescribe a second-generation AOM? I want to be prepared for the worst-case scenario to feel comfortable prescribing these medications.
So again, a great question. We always have to think about what kind of calls are we going to expect? What kind of things do we see with our patients? And I'm sure most of you have comfort prescribing these as well. So you know what comes into the office or what calls you get. A lot of times it is going to be those GI side effects, and they're going to be asking you about those. But what is the worst call about side effects that you could expect? So thinking about worst case scenarios, right? So we think about that pancreatitis, not ideal. So we are going to be watching our patients again for any symptoms and working them up. The incidence of pancreatitis in these trials were really pretty low, but that is one that obviously you're going to want to take seriously. And if a patient does develop pancreatitis on these medications, obviously rare to stop them immediately and not go back to them. Hypoglycemia, we do want to pay attention to that, especially in our patients who have type 2 diabetes and are treated with medications that could promote hypoglycemia, specifically insulin or sulfonylureas. So when you have patients coming in on these medications and then you add semaglutide or tirzepatide, you just want to really be careful. I honestly try really hard to work with their primary care or endocrinology, whoever's managing their diabetes, to really help get them down off of insulin or sulfonylureas, because we also know that not only do they promote hypoglycemia, but they can also be obesogenic, or they can promote weight gain. And so I really try hard to help our patients come off of these medications. Plus, they are going to get that glycemic control from the tirzepatide and the semaglutide as well. So really, they're not going to most commonly be needed, especially the sulfonylureas. Of course, you're going to watch patients closely. We wouldn't stop insulin immediately. I have them call me or message me consistently, constantly, sometimes daily, just to give me their sugar numbers, and we taper down on insulin, but and try to get them, if they have to be on insulin, just the lowest dose that they need to do. Hopefully our patients with diabetes also have access to the CGMs, or those continuous glucose monitors, so that they're able to pay attention to their blood sugars as well. And also I find that nutrition is key for this as well. So reminding our patients that when they're on these medications, they're going to have appetite suppression. So if they are on insulin and sulfonylureas, they absolutely need to make sure that they are getting adequate nutrition and calorie intake. Hypersensitivity reactions, that could be a call, of course. We just want to stop the medication. Acute kidney injury. So we really don't think that it is as much the medications themselves that causes the kidney injury as much as it may be the volume depletion that happens from the medication side effects. So again, monitoring our patients closely for signs of dehydration and just remembering to remind them to drink liquids. They can't chug because liquids are not going to fit in large volumes very easily due to the delayed gastric emptying from the medications, but remembering to just sip their liquids so that they can hopefully head off any acute kidney injury. Severe GI disease, of course, if patients are really just struggling with tolerability, then again, this may not be the best choice for them. I know that gastroparesis, that's one of the mechanisms of how these medications work. And so patients sometimes will hear in the media that these medications are going to cause gastric paralysis, or they're going to paralyze their intestines. If they are experiencing severe gastroparesis symptoms, then of course we're going to want to stop the medication. Also, patients who already have severe GI disease, these may not be the best choices for them as well, because we know, again, those most common side effects are GI. So it really is a conversation with your patient and just a close follow-up and making sure that they're tolerating them, that they're getting their fluids, and that we're working up any symptoms that seem suspicious. Diabetic retinopathy. So what we think with these medications is not that they necessarily cause that in themselves, and these are still being investigated and they're new, of course. So we don't have as much long-term data as we'd love to see, but we do think that the diabetic retinopathy that may flare on these medications actually comes from rapid fluctuations in blood glucose, more so than the medications themselves. So again, with our patients with a history of diabetes, we really hope that they are staying in closely with their ophthalmologists and getting checked routinely. And then acute gallbladder disease, in trials for these medications, there was a small increased incidence of gallbladder disease. We also know, though, that when patients are trying to lose weight, or when they do lose weight, they can increase acute gallbladder disease as well. So weight loss in general can cause an increase in gallbladder disease. So again, supporting our patients, watching for symptoms, working them up appropriately. So now thinking about other factors when it comes to medication options. So our factors, provider factors, how comfortable are we with these medications, and what is our experience with them? So that's why I'm very glad you're here, so that maybe if you don't feel comfortable using these medication options, you will feel more comfortable and be able to introduce these to your patients. However, I know that in primary care, we have much experience treating diabetes, and these medications are not something new to us. It's really just when they relate to obesity that has been more recent for all of us, and developing our comfort when we use it in that way. So what are the obstacles when we think about treating our patients with obesity? So of course, we are busy. In primary care offices, you are terribly busy. You have numerous things you're trying to accomplish in a visit. And then, oh, by the way, we need to address their weight and have those sensitive conversations and bring this up and talk about lifestyle changes and how in the world do we get this in? So we could certainly talk about that. And next week, if you want to, I started in the primary care world, and I added this obesity treatment to my patient care for the last 6 years or so of my primary care career. So it is challenging to do. And we can talk about ways that it worked for me to try to help treat obesity. Because again, we know if we can start there, then we really can treat these other conditions that we are addressing every day in our offices. So thinking about us being busy when it comes to treating obesity, in fact, if we start with obesity first, we will be treating these other conditions anyway. And so it's interesting, clinicians are busy treating other important chronic diseases. I think obesity may be one of our most important chronic diseases. Clinicians lacking comfort prescribing weight loss interventions. So again, it's great that these medications have been around for diabetes first, because again, our comfort level with them for that reason is much clearer, much easier. We do have more comfort there. I know in the past, before we were using these medications, the first generation anti-obesity medicines, we were not as familiar with them. And especially the ones like phentermine, which were controlled substances or still are controlled substances, there is a lack of comfort for us in our training using controlled substances in general. And so fortunately now, having the second generation of medications, that hopefully we will be more comfortable. There's also some misconceptions around treatment of obesity and treatment of obesity with medication. We used to think, I think we're getting better at this now, but we used to think, I was trained, that medications were kind of a cop-out. They were because a patient didn't have enough willpower on their own. Maybe they weren't safe. Unfortunately, we do have too many of our previous anti-obesity medications, which have been pulled from the market for various problems or issues the FDA identified, like phentermine with fenfluramine. So that fen was one of the first ones that was pulled from the market. And so I think the more that happened, the less comfortable we became treating patients with anti-obesity medications. So hopefully as we go and the more we know about these medications and the safety data that we see, that will help us be more comfortable as well. We also, I think, I was trained that if we are going to use medications for obesity, especially phentermine and these controlled substances, that we can't use them long term. So the comfort around using a chronic medication for a chronic disease is kind of a newer concept as well. So, so hopefully we are getting more comfortable with the idea of the chronicity of treatment for our patients with obesity. And then patient factors, of course. So we have to think about cost, coverage, patient preference, access to the medications. That is certainly a factor. So we're going to see what Mr. J has to say.
Oh, okay. That makes sense. What about the side effects? I read something on Facebook about these medicines that I didn't like.
So I think what we had decided to do was start Mr. J on one of these therapies to help his diabetes, his liver disease, his obesity, and his comorbidities. So he's asking now, what about our side effects? So side effects, again, if we educate our patients and we just help them through, especially these GI side effects, I find that they are usually really pretty temporary and manageable. I usually warn patients that the worst side effects are going to be about the first 24 hours after their first injection. So making sure they do it on a day or an evening where they don't have much going on the next day. I also will talk about other tips and tricks, but I make sure that they are eating lighter, leaner foods when they start these, because that will also help mitigate some of those GI side effects. And I also don't have problems supporting our patients through these with medications to help with, say, nausea or GERD or constipation, helping our patients prepare for those with other medications that we can use. Because again, it's going to be temporary as we're getting them over these side effects. So looking at these side effects specifically in some of our trials, so you can see with the SURPASS trials here with tirzepatide in diabetes, that you can see nausea. And usually the nausea, the red is the severe nausea with the different doses. And the nausea was really not as severe as you would imagine. And even when you see the tirzepatide 15 milligram dose, the severe nausea was very minimal. So, and it tends to be worse in the beginning. As you can see, the bottom are the weeks of time patients are on the medication. And you can see that nausea really does improve over time. Same thing when we look at semaglutide, incidence of nausea over time in our STEP trials. So these are the obesity trials. And so you can see on the right, the nausea really peaked at about week 20 and then decreased after that. So again, that's also why we do that dose escalation on these medications monthly to help them get over these side effects, but they are relatively short-lived. So we can help our patients with these side effects. I give them tips and tricks. So number one is slow down when we're eating. We know these delay gastric emptying. So if they are trying to eat quickly, the brain does not register fullness for probably about 15 minutes or so. So they need to slow down and really monitor for those signs of fullness. So eating slowly, smaller portions, not skipping meals necessarily, but maybe smaller portions of food throughout the day. Eat when they're hungry, so monitor hunger symptoms, and then stop when they feel comfortable. I don't even tell them stop when they start to feel full, because at that point it might be too late. So stop when they start to even just feel like, okay, I'm not hungry any longer, and that would be a great place to just slow down and see, do I need more food? Taking less food on their plate, the brain sees a certain amount of food and thinks that that is going to be what will fit, and it doesn't. So smaller plates, smaller forks. The types of foods. So we know that a fatty meal is going to feel worse. So on that Friday night starting the medication, I would not do it on Friday night pizza night, because that's not going to feel as good. Stay upright. So other type of GERD precautions that we give our patients as well. All right, so let's see what Mr. J has to say.
Oh, okay. Okay. I will take it if my insurance covers it. But do I have to take it my whole life? What happens if I stop taking it?
So again, good questions. So do I have to take it my entire life? And I hear this question a lot from our patients, and it's a valid question. You know, we don't really want to have patients on medications if they don't need to be on them long term. And so I explain to patients, I would love for you not to need a medication. That would be wonderful. And we'll see what happens. Everyone's different. You know, if you have made lifestyle changes and you are being consistent with your nutrition changes and your physical activity, and sleep is good, and sleep apnea is being treated, and stress is manageable, and all of the other pieces are in place, then maybe not. And we can, as we go along, we can see. You know, I follow up with my patients quite frequently so that we can be monitoring this. We do know that obesity, again, chronic disease. So I do try to explain to patients that, for example, hypertension. If a patient has hypertension and we put them on a blood pressure medication, the expectation is most commonly they are going to be on that medication long term. So we should think about obesity in the same way. Studies have been done to show that when patients do take a medication, such as semaglutide and tirzepatide, and then they stop the medication, what happens over the next year is that they do tend to regain about 2/3 or so of that weight back. And that's not because of their failing, and it's not because they lack willpower. It is because of the disease of obesity. I also explained that this is genetics, and there are hormones, there are hunger signals and fullness signals, and so many things outside of their control that if they stop the medication and the weight starts to recur, it doesn't necessarily mean they're doing anything wrong. It means this is the biochemistry of the disease of obesity. We explain that medications change this biochemistry when you take them and when you stop them. Unfortunately, if you don't have enough of a satiety signal in the brain, if you have too much of a hunger signal in the brain with these hormones, then they're going to go back to where they were. So again, remembering that this is physiology, this is biochemistry. And I tell patients too, we are in this for the long haul. I'm in it with them until they decide they're done, but I hope they don't, because this is a lifelong disease. And so our frequency of visits do tend to be stretched out as they feel like they're doing well and they just have this down as a lifestyle. But I still tell them that we're in it for the long haul. This is something 30, 40, 50 years we are going to be talking about. If I'm still working, we'll be talking about and we'll be managing, because this is something that does not get cured. This gets managed. So thinking about our post-test question number 2, to facilitate shared decision-making, what counseling and education points would you provide for patients regarding these second-generation AOMs? So we're going to see how you do with the question again. Right. Yeah, but it looks like we've got it. So I'm just going to end our poll here. But yes, remembering obesity is a chronic disease, and that this therapy is going to adjust the physiology while they're taking it. Great. Now, how do we dose these medications? So you're familiar with the dosing. I'm sure that we are escalating dose usually monthly. And you can see semaglutide and tirzepatide doses. There are 5 doses of semaglutide and 6 of tirzepatide. The purpose of this is to help our patients get through those initial GI side effects. Now, when we look at efficacy, though, we can see weight loss happening from the beginning of these, the use of these medications. So I have patients ask often, well, how long is it going to take before I start to see weight loss? And they really do see it pretty immediately for the vast majority of people. Now, I do have some people who start the medication and they get through about mid-dosing and they say, I'm not really noticing appetite suppression. The weight loss isn't really as dramatic as I thought. But when you look at the dosing, you're really doubling it, especially when you look at semaglutide, 0.25, 0.5, 1 milligram, the top dose being 2.4. So I explained that we still have, some room to go. And then much more often than not, patients do start to respond. Depends on what dose they respond to, but they do eventually respond the vast majority of the time. So our post-test question 3, last question, second-generation AOMs were initiated with your patient. They report they've been experiencing some GI side effects. So which of the following ways are the best ways to manage these? Great. Yep. I see that we all know the answer. So we're going to titrate the dose slowly. And that's, again, why we have those multiple doses of medications and why we do it on a monthly basis. Some patients will say, I don't feel anything yet. Can I just skip through the next dose? Or can I just do the next one for a week or two and keep moving faster? The recommendation is that we don't do that, that we do it on a monthly basis. Right. So let's see what Mr. J has to say.
Doctor, I'm sorry to bother you. I want to see if you can help me with some nausea that I've been having when I started on the higher dose. It's not really bad, but I don't want it to get worse. Thank you so much for your help, and you have a nice day. Thank you.
So we started Mr. J on tirzepatide. His insurance covered tirzepatide treatment, and he began that, and he started the dose escalation. And so 6 weeks into his treatment, so probably into the second strength of the medication, that he is having some side effects. So again, thinking about our dose escalation, sometimes we even need to stay at the same dose or even go back to a lesser dose for an extra month. So there is no schedule that you have to necessarily follow. Of course, this is going to be up to how your patients are tolerating the medication. We do know, though, that when we look at insurance coverage on these medications, one difference that I've noticed is that with Wegovy, insurances don't tend to cover as maintenance doses the first 3 doses. So the 0.25, 0.5, and 1, they are meant to be the titration doses, and insurance is much more likely to cover maintenance doses at 1.7 and 2.4. With Zepbound, the approval was for all of the doses, but it's intended for the 2.5, the 7.5, and the 12.5 doses to be, again, those titration doses, with the treatment doses being 5, 10, and 15 milligrams, because those were the ones that were studied in the trials. So dose escalation. So, talking to your patients and making sure you're doing that follow-up with them just to see how they're tolerating it. Do they need to go back on a dose, or what do we need to do? We also want to make sure that we're watching for other conditions. Sometimes patients come in and they say, well, I am feeling back pain or stomach pain or something that you think is maybe not related to the medication. So just remembering that there are other conditions happening. Maybe they have a urinary tract infection. Maybe there's something else going on. And so kind of just keeping our minds open to other things that could be going on. Now, I do also support my patients if needed with medication. I have no problem prescribing ondansetron, Phenergan, something to help them get through those initial side effects, because I really do feel the benefits of the medication greatly outweigh those initial side effects when they are mild, or moderate even. So helping our patients get through those with some medication. Again, reminding them about hydration. Diarrhea, if that happens, we have medications they can even take over the counter. Constipation, I remind patients about a bowel regimen to include fluids and some fiber and some exercise and Colace or stool softeners, Miralax. There's so many different options to help our patients with those side effects. So in our case study, Mr. J, he started medication, he started tirzepatide, and now we have follow-up data. So we have his baseline data there. We have his follow-up data at 6 months and 12 months. And you can see that he has done remarkably well with his glucose control. His A1C went from 8.1 to 5.8. Blood pressure has improved. His HDL actually increased from 38 to 48. These medications are not FDA approved to specifically treat dyslipidemia, hypertension, but you can see the benefits here that we're getting in his cardiometabolic profile. You can see here also that he has lost some weight. He has a 24% body weight loss, and he was able to stop glimepiride and hydrochlorothiazide. I actually, when I was reviewing this case, my first thought when I looked at his medications, because when we think about treating our patients with medication, anti-obesity medicine, we talk about treating them with medicine. But when I talk to patients, I also say medications to me means 2 things. It also means let's look down your medication list and see which medications we are giving you that put you at risk or that could be obesogenic. And so glimepiride on that list would have been one of the first ones I would have thought to stop, if I could have, when I had started the tirzepatide with Mr. J. So that would have helped weight. I think his glycemic control would have still been very good without the glimepiride. We would not have had to worry about hypoglycemia. And so he was able to stop that medication anyway. His FIB-4 score improved, his liver enzymes improved, and his risk went from, and his obesity class went from class 2 to overweight. His risk went from very high risk to an increased risk. So much improved health of your patient. Now let's take some community questions from our clinicians.
How do I handle a situation where the patient wants medication for weight loss but hasn't tried to make any changes in lifestyle like diet and exercise?
Yeah, so that's a great question because I hear from physicians and providers sometimes that they want to see that the patient's serious. They want to see that the patient has tried, that they have to put their effort in before they will then prescribe a medication. And there are different ways to think about that. You know, I explain to patients when they come into me that this is not about you're going to get that injection because you heard that injection is wonderful, your friend is on it, and you just want the shot. Give me the shot. It doesn't work that way. We know we don't do that. It's a comprehensive approach when we look at weight. We want to look at all of our tools. We have to look at our lifestyle changes. That's the foundation for our obesity treatment, and that's what's going to carry patients forward for the rest of their lives. So the medication treatment has to go hand in hand with our lifestyle changes. But what I also explain is that these lifestyle changes are difficult. We know, any of us who've tried to lose weight or watch our diets and exercise more, it is difficult. We are busy, we are stressed, we get food cravings. So what I find with these medications is that they really do help our patients with appetite, cravings, thoughts of food, so that now they can do what they know they want to do in the way of nutrition. They want to eat better. They know what junk food is most commonly, especially when you educate them. They want to do that, but the brain is powerful. These hunger signals and cravings are powerful. And so these medications can really calm that down. So now our patients are able to do what we know we want them to do. So I really feel like it is beneficial to start these earlier as opposed to later. But I also follow up with them routinely. And I tell them, okay, we're going to follow up in a month and we're going to see how you're doing. We're going to talk about what changes have you tried to make? Where are you? And if they're struggling to do that, we talk about why. Is it stress? Is it sleep? Is it their mom just died? You know, what is going on in their lives that's standing in the way?
Hi. How can I be sure to be reimbursed for an obesity visit, and how do I know what the correct coding is to bill for? Any help would be appreciated. Thanks.
Yeah, this is a great question because, you know, we are all in this to help our patients. We are all in this to improve health, right? But we have to be realistic that our time is valuable and billable. And so we need to be aware of how to do that in our offices so that we can continue to provide this service. So there are lots of tips and tricks there as well. And we can talk about that depending on your situation. And if you have any questions about that, the billing is nuanced to some degree. So it depends on their insurance coverage. It depends on whether they have coverage for anti-obesity medications. So when we think about our medication prescribing, it also depends on different insurances don't recognize obesity as its own standalone disease. So oftentimes, we have to code a comorbidity first and then address obesity next. We're addressing it every visit, and we can address a comorbidity because they relate. So if we just document the comorbidity first, then oftentimes that does get covered. So we can talk about this. This is a long question. This could be a lecture in itself. Dr. McConnell is maybe on the call. He's also in our Florida Obesity Society, and he is kind of our expert on coding and billing and insurance for obesity treatment. So you can always pick his brain next Thursday as well. All right, so that got me through, and 2 minutes to spare. So I think there are some notices that we're going to talk about with our claiming credits.
Well, thank you so much, Dr. Ferreira. That was excellent. I am so excited. I'll get to meet you in person next week and everyone else. If you are interested in claiming credit for continuing education for this activity, please use the QR code on the screen. Thank you again. If anyone has questions, now would be an excellent time to go ahead and put them forward for Dr. Ferreira. And if anyone wants to put them in the chat, we can also address those as well. Where's the QR in the chat? So Dr. Ferrer, if you'd show that slide again, that would be lovely. Thank you.
That's showing up okay?
Looks good. All right.
Great.
So once you all get your credit, thank you again and have a good evening. And we're excited to see you in person next week.